So let's look at some lab values, which is another way for us to assess or observe our patient and make some determination. First of all, we want to look at the hemoglobin. Depending on where you are, you'll see it abbreviated as HB or HGB. This is a protein molecule on the red blood cell that carries oxygen from the lungs to the body's tissue, but it also carries our wonderful friend carbon dioxide back to the lungs to be expelled out and all that good fun stuff. So it's usually part of a complete blood count or a CBC, but you can also test just for the hemoglobin. Here are some normal ranges, male and female, 13.2 to 17.3 for the male, 11.7 to 15.5 for the female. Keep in mind if you have someone who has underlying disease process like your anemias or whatnot, these are gonna vary, okay? But these are traditional healthy individuals, okay? And as you see here in the picture, there's a illustration of what a hemoglobin molecule might look like on the red blood cell. So there's more to blood than a hemoglobin. But it's mainly the red blood cell and the white blood cells, but they're suspended in a serum called plasma. It's usually pretty clear in nature. We also have the hematocrit that indicates the percentage of blood by volume as composed to red blood cells. Anemia is the result of having too few red blood cells. Hypoxemia. The average hematocrit in a male is 38 to 51, female 33 to 45. The adult pregnant woman, it does lower a little bit to 30 to 34% because they're sharing with the fetus or the baby. Um, so oftentimes a person who has a decreased hematocrit and hemoglobin will present with some shortness of breath or dyspnea. You see how I talked about that being written out. Weakness or lethargic or listlessness, okay? They just don't have any energy. They don't have anything carrying their blood around, so or their oxygen around, so they struggle a little bit, okay? So a lot of things make our blood oxygen levels low, ranging from chronic disease to issues just in general. COPD, including bronchitis, chronic bronchitis and emphysema, acute respiratory distress syndrome, asthma, collapsed lung from trauma, anemia, congenital heart defects, heart disease, chronic heart failure, a pulmonary embolus of whatever type. And our best intervention is a blood transfusion, but we don't want to just go right to a blood transfusion, although that's going to be the best help for us. But there are lots of reasons behind that. So going to talk about a couple things that you may not actually see as a first semester student until you start digging into the patient's medical record for this visit, where they may have been in a critical care unit beforehand or at a higher level care and have had some of this stuff done. Capnography measures the level of carbon dioxide in the inhaled and exhaled air. Um, it's a beam of infrared light that passes through a sample of respiratory gases. A special way to do this. It's not something you always monitor at a bedside. Arterial blood gases or ABGs. You'll also see or somebody say, "Hey, how was Mr. Smith gases this morning?" This is what we're talking about. This is the most accurate measure of oxygen, CO2, and bicarbonate levels in the blood. This is the most accurate measurement of oxygen and carbon dioxide and bicarbonate levels in the blood. Okay, so this happens when we take a needle and insert it into one of the arteries. The picture here shows the person doing it in the radial artery. That's the preferred method to obtain arterial blood. It can't be venous blood. A venous gas can help us, but not as well as an arterial blood gas. It's very advanced. So they pass the needle through the skin into the artery. They withdraw a little bit of blood or arterial blood. It should be nice and bright red. Your needle also may pulsate because it's into the artery. Uh, this is actually rather painful. So don't tell your patient it's not going to hurt. It will because it mainly hurts because when you hit that artery, the artery spasms and causes the muscles around it to spasm and tighten as well. What's also important here is after this is done, that the individual holds pressure on that site for a few minutes so that it clots and they don't actively bleed. Okay. So maintaining a patent airway is our goal. in order to maintain oxygenation. And as a nurse, we may have to use an artificial airway on our patient for some reason or another, in case it becomes blocked or whatnot. So it's important for you to understand the differences in what you can and cannot do, or should not do. Um, so we do it for various reasons: thick secretions, occluded airway from the tongue or an object or whatever. Page 957 has some examples for you. We have an oral airway or a pharyngeal, nasopharyngeal, endotracheal, or tracheostomy. So the photos you see here, the top one is an oral airway. Okay, you should only put that in an unconscious individual because it will invoke a gag reflex. So your awake person will vomit on you when you do this. Okay, if someone is awake but they can't maintain an airway, you can insert a pharyngeal airway. That's the middle one, the orange looking tube that's going into the mannequin. It's very, very flexible. It goes down the nasal airway, past the tongue, and sits very similar place. But an awake person can tolerate a nasopharyngeal airway. Okay, the next one is you can insert, as a nurse or a nurse aide, you can insert an oral or a nasopharyngeal airway. You also should be covering those when you do your basic your basic life support courses through the Heart Association. The next picture in the bottom is an endotracheal tube. That requires special education and teaching. A respiratory therapist can do this, a CRNA or a registered nurse anesthetist can do this. If you're on the flight team, all that kind of fun stuff, you can do this. In this case, we take a tube that has a stylet through it, and we use another piece of equipment called a laryngoscope. We take the laryngoscope, we go down the tongue, lift it up so we can visualize the vocal cords, and then we take this straight tube with a stylet to help support it, pass it through those cords, pull the stylet out, and then we can attach an ambu bag to the tip of this to mechanically breathe for the individual. Tracheostomy is a very similar tube, much smaller, but it is inserted at the cricothyroid and helps with, or is an artificial airway, and you will see multiple pictures of those at some point in life. So suctioning is very, very important to do for people who have airway issues, a lot of secretions. You may see this with strokes or people with tardive dyskinesia, just any number of reasons. Um, what's important is that you only suction on your way out, not going in. So different types of suction catheters and devices. The one in the upper corner is uh, it should be sterile. It can go down the nose. It can go down into through a tracheostomy tube. It can go through an endotracheal tube. It can also go down the side of the mouth. And one end of it is hooked to a suction catheter or a suction tubing that goes to a suction canister. And over this part, we put our thumb to seal it, and there are holes through this tube that allow the secretions to go through. This is called a Yankow or oral suction. This is very hard, pliable, something very similar to what your dentist would use when he's working on your mouth. Person can hold this themselves if they need to. Be careful when you stick this too far in, it may cause them to gag. Okay, so we replace most of these, especially the one up top, after every use because it's no longer sterile. Don't use water or solutions to loosen secretions. You need to suction. You should also only suction for 10 to 15 seconds at a time before you give oxygen or allow the person to try to breathe. Um, so we suction airways to remove secretions and maintain patency. It also removes oxygen as well, so it needs to be done quickly. Open tipped is what we see down here. Uh, Whistle tipped is what we see up here, and a whistle tip you can't delegate. An NA can oral suction, but they can't do the other. Okay, so in your textbook, um, volume 2 has all the instructions on how to actually suction. We'll talk about that in the Sim Center, so you'll need to be aware of that. It's testable material.